Hello everyone and welcome to our mini lecture number 7 and final mini lecture in the opioid unit. Today we're talking about the treatment of opioid use disorder. So I'm sure it's not news to many of you that we are in the midst of a health epidemic in terms of the opioid crisis in this country. As I mentioned earlier on in this unit, since 1999, overdose deaths have skyrocketed, nearly quadrupling according to some estimates. The origin of this problem is complicated in nature. Many people look to the overprescription and use of opioid painkillers, and then these harsh sort of cutting back on those measures, leading to a lot of people with dependence and nowhere to turn to. Some areas of the country are hit harder than others by that. In addition, we saw the popularization of several really potent synthetic opioids, such as fentanyl. Pictured here is the lethal dose for an average-sized person of heroin and fentanyl. As you can see, fentanyl is extremely potent. Oftentimes, supplies of opiate drugs on the street are cut with fentanyl to increase their potency. This can be extremely dangerous, as oftentimes people buying these drugs don't know exactly what's in it, and the incredibly increased potency can be very dangerous. Fentanyl is so potent that, even a few grains, as you see here, can be sufficient to kill an adult person. And there have been issues of first responders and law enforcement suffering an overdose from just physical contact with a sufficient quantity of fentanyl. So let's move on to a discussion of exactly what treatment options exist. Always the first step is detoxification, or getting past withdrawal. The withdrawal state for an opiate addict is extremely unpleasant. And as we spoke about with the negative or the dark side of addiction, that negative reinforcing property of removing the withdrawal state is a very strong motivator. So this withdrawal process can be assisted by long-acting opioids such as methadone, and we'll talk about exactly how, but methadone can reduce the symptoms and provide relief to people in a withdrawal state. This dose can be tapered if the individual is motivated to do so, to reduce use over time and sort of wean themselves off of the drug. Though relapse is the most common outcome, and most people, the best option is to remain in maintenance therapy indefinitely. In addition to opiate drugs like methadone to ease withdrawal, clonidine could be prescribed, which is an alpha-2 adrenergic agonist. If you forget what that is, you can go back to our unit on norepinephrine. But this goes back to what we were talking about earlier, with the locus coeruleus activity being activated or being increased after withdrawal state. Remember, because opiates suppress activity in the locus coeruleus, the withdrawal state involves a rebound and overactivity of that region. So since the alpha-2 receptor is primarily expressed as an autoreceptor, by agonizing these autoreceptors, you can actually sort of tone down that overactivity of the locus coeruleus. So moving on to discussion of methadone maintenance. This approach is the long-term substitution of methadone for heroin or another abused opiate. This serves to sort of reduce the cravings and withdrawal state associated with abstinence and allow the patient to live a more normal life. This allows for the direction of energy away from drug-seeking behavior and towards what might be more productive activities like pursuing education or finding employment. This is currently the most effective treatment we have in terms of harm reduction, meaning that people are more able to stick with this than some other options that exist, and it allows people to have some semblance of returned quality of life. There are downsides. This requires supervised daily oral administration to curb diversion, because methadone does have some abuse potential if it is administered through other means. It is administered through oral daily administration to ensure that it is not diverted. This means that people making use of these clinics must travel to the clinic each day and spend a significant amount of their time and energy maintaining this treatment program. This does produce little to no euphoria, so it's not as if people in methadone maintenance are getting high daily on methadone. It's simply removing the negative withdrawal state as much as possible. And this also can foster cross-tolerance, meaning that if there is a resumption in use of an abused opiate, it should, in theory, blunt the euphoria. So another property of methadone maintenance is it produces long-acting constant levels in the blood. So instead of using something like heroin, which is going to spike and then rapidly deplete, methadone produces a stable experience that serves to better normalize body function. In addition, especially with the better methadone clinics, contact with staff can facilitate therapy, counseling, educational job training, and support. So these clinics can be a good resource for people attending them. Though that said, that's not often the situation. Methadone clinics are often underfunded and understaffed and are not able to meet the needs of their patrons in this way. Another approach is buprenorphine, which is an opioid partial agonist. So whereas methadone is a full agonist that sort of has a slower peak and more gradual withdrawal, buprenorphine is a partial agonist that produces weaker effects over a longer duration through a different mechanism. So it binds to opioid receptors but activates them less strongly than a full agonist would. This allows for more intermittent dosing, so doses can be taken 1 to 3 times per week instead of daily. This means reduced cost for the funding of these services and more freedom for the people who are using them. However, this approach may be harder to obtain because not all clinics offer buprenorphine, and it may be more poorly tolerated. Often people report having a more negative experience using this as a means of curbing withdrawal. In addition, there can be use with compliance and subsequent overdose risk. The partial agonist property of this drug means that it will blunt the effectiveness of other opioids, right? Because this drug is competing with any other opioids that might be in the system, there's going to be less binding of the full agonist at the receptor sites because the partial agonist is getting in there, binding, and producing a smaller effect than the full agonist would. So, much more of a full agonist would be needed to achieve the same high because of the competition with the partial agonist. Because of this, if people decide to start using again, that means they'll have to stop taking buprenorphine because it will interfere with that process. So that is a compliance issue, and trying to overcome the partial agonist effect by using a full agonist drug of abuse can pose a dangerous overdose risk, as it's not going to be the same dose that the user would normally use. Suboxone is another drug that is used for a similar purpose. This contains both buprenorphine and naloxone. And remember, naloxone is the drug that first responders use. It's a competitive antagonist that will outcompete opioids and prevent their effect. So this is typically taken sublingually, so under the tongue, if you remember back to our earliest units on routes of administration. So if it's taken sublingually, buprenorphine will be absorbed, but the naloxone will not. So this will result in a controlled administration of buprenorphine. So it resists things like being crushed and administered in other ways because of this property. If it's crushed and injected, naloxone and buprenorphine will both become available, and the naloxone will block the euphoric effects. So it curbs abuse potential because it cannot be abused by using a different route of administration. It must be administered sublingually, or it will not achieve its intended effect. Additionally, there's a newer method of approach of administering buprenorphine, which is probufene, which is a implantable buprenorphine treatment. They're these small little rods that are about the size of matchsticks that can be implanted under the skin of the upper arm. Again, this poses some of the same issues that buprenorphine itself would pose, but it's very convenient, and that allows for good compliance and steady delivery of the drug without frequent treatments or trips to a clinic for treatments. It's also impossible or extremely difficult to divert the substance, as it is implanted in a matchstick-sized implant in the arm of the recipient. Some therapies make use of antagonists, such as naltrexone, which is a long-duration, so sort of slow-release formula of a competitive antagonist. It can be taken orally, so it's convenient to administer. This is really good for highly motivated individuals, as it will sort of prevent abuse, right? Because the antagonist is on board, you can't return to opioid use because it's hard to overcome the binding affinity of something like naltrexone. However, this does not eliminate the craving, so many will stop using the antagonist and return to opioid use. So it has limited effectiveness. It might be a good approach for certain populations, but doesn't really see widespread use. So just kind of a word on what a feasible approach might be, you might notice a lot of the stuff that we're talking about doesn't involve a traditional therapy, but what we know is that a multidimensional approach is best. Successful treatment should include a detoxification period, pharmacological support to help deal with withdrawal and craving, and group or individual counseling to sort of help identify environmental factors, behavioral issues, etc., and help to sort of form a behavioral plan that can help the addict recover. Narcotics Anonymous is another option that uses some of these elements. But the unfortunate state of things is our medical system to treat people who are trying to recover from an opiate use disorder is severely underfunded, and most people just sort of end up on a maintenance therapy program indefinitely. Without proper support and reintegration into society, it's hard to do that. So ideally, we would have all of these elements present, a guided detoxification process, pharmacological support for all of the issues, including withdrawal and cravings, and group sort of counseling or individual counseling to deal with the psychological effects and to help the patient form a plan to stay on the right track to recovery. Okay, so that is it for our treatment mini lecture, and this closes up our opioid unit. So I'll see you next time.